Hello, everyone. My name is Rochelle Miller. And for those of you that don't know me, I am the BC PAD pharmacist for the Northern Interior and the Northeast. So please reach out to me if you're ever interested in a PAD session. Today, I have the delight of introducing you to a wonderful team that will present to you on their polypharmacy risk reduction project. So today you're going to hear from my colleague and close friend, Dr. Charles Helm, who his reputation for patient-centered care is unmatched, and he's probably sparked some of your re-interests in dinosaurs over the course of the years. We also have the pleasure to hear from two pharmacists. First pharmacist that you're going to, I'm not exactly sure what the order is, but I'd like to introduce you to Sydney Saunders, based out of Dawson Creek. And she's doing amazing work in the primary care setting with a passion for health and wellness. And even she keeps even our department very mindful of everything that we're doing in our personal and professional lives. Also, we have a Charissa, who is an accomplished and world-renowned martial artist, who is also one of the pharmacists out of Tumbler Ridge. We have Charleigh Rudy, our Southeast Division Coordinator and Practice Support Coach, with expertise in a wide variety of fields, such as emergency oncology, as well as primary care. And last but not least, we have Christy Demeter, is our first contracted PCN nurse practitioner in Northern Health, and is always an asset to all of the communities that she works with her outstanding work in polypharmacy projects. So with that being said, please enjoy this presentation. They have put their heart and souls into it, and they're doing phenomenal work all throughout the region. Thank you.
Thank you kindly for that introduction. So good afternoon, everybody. My name is Charleigh Rudy, and I am the Southeast Division Coordinator. I wanted to start off by acknowledging that we are joining you from the traditional territory of Treaty 8 First Nations, where we live, work, and play. We really want to thank you for providing us with the opportunity to share the innovative work the Southeast has been doing related to our shared care project on polypharmacy. We can go to the next slide. The learning objectives that we will be exploring today include discuss how we started the project, define the project purpose, and explore what made it unique, review project achievements, apply case presentations, identify what worked well and what we might want to do differently next time, and consider how to sustain this work. Next slide. The Southeast is located in Northeastern British Columbia and includes the communities of Chetwynd, Dawson Creek, and Tumbler Ridge, as well as Peace River South Rural, including the First Nations communities of Kelly Lake, Soto, and West Moberly. The total population of the Southeast is 26,665 people. The distance between each community in the Southeast is approximately 100 kilometers apart. Next slide. We do really want to take the time to acknowledge our diverse working group for this project, which included physicians, nurse practitioners, community pharmacists, primary care pharmacists, internist and evaluation support from UBC Therapeutics Initiative, Northern Health Evaluation Support, Divisions of Family Practice, Practice Support Program, Physician Quality Improvement, and our project manager. The diversity of our team has led to many successes and a great opportunity for relationship development amongst professionals within the Southeast and outside of the Southeast. Truly team-based care. For the project overview, one of the main goals that we wanted to focus on was increasing the appropriateness of medications for older adults aged 65 plus taking 5 or more medications. We started this work in May of 2020, and we focused on 4 key areas. We looked at education in polypharmacy, team-based medication assessments, transitions in care, which included improving the medication reconciliation process, and lastly, evaluation. And we will explore each of these areas further throughout this presentation. Our first priority was education in polypharmacy. The Shared Care Working Group hosted a total of 9 webinars from September 2020 to September 2021. The topics of the webinars were selected based on information received through evaluations that were supported by Northern Health and UBC Therapeutics Initiative. The webinars were CME accredited and have been recorded to share learnings within the Southeast and beyond, and you'll find a link to that in the chat today. Presenters have included physicians, geriatric psychiatrists, nurse practitioners, pharmacists, and we even had our local community paramedic from Dawson Creek present at one of the webinars related to health home monitoring and hypertension. Some cases have been selected and shared at the CME learning sessions and have been so inspirational to hear the patient voice and how medication assessments have impacted their health. We've had various presenters with different backgrounds from different communities in the Southeast and beyond, and we're very thankful for everybody who has contributed. We've also received some very positive feedback from our attendees at the webinars. This feedback has been so powerful, as you can see how these webinars are being utilized to inform practice and the importance of patient-centered care and empowering patients and families. Next slide. Our second priority was related to transitions in care and improving the medication reconciliation process between hospitals to the community. And this is a priority, but also a challenge for us. From our initial evaluation for this project and support from community pharmacist tracking, we heard that communication from the hospital to the physician clinic and community pharmacist was inconsistent, resulting in high risk for medication errors. For example, missing medications from before admission, unclear whether to continue medications, therapeutic interchanges, and lack of drug coverage as examples. With competing priorities related to COVID, the Shared Care Working Group had challenges getting traction related to these gaps. However, we are very hopeful that the seeds have been planted to continue to move this very important work forward. And now I want to pass it over to the physician lead of this project, Dr. Charles Helm.
Thank you, Charlie, and good day, everybody. It's really good to be with you, and thank you for this privilege. So I'm coming to you from Tumbler Ridge, which is a very beautiful part of Canada. We deal in waterfalls and dinosaurs. There's Kunisea Falls in the middle, and we have 2 dinosaur trackways on the outside of that photograph. And as a result of these features, we are a UNESCO Global Geopark in Tumbler Ridge. So continuing the project overview, the team-based medication assessments, this was really the hub of what we were trying to do. So we had 3 communities, Dawson Creek, Tumbler Ridge, Chetwynd, and we each approached it slightly differently. As you can see in the bottom line there, in Dawson Creek, it was the patient plus the primary care pharmacist, Sydney, with a lot of help from Christy, our nurse practitioner. In Tumbler Ridge, it was the patient having sessions with the pharmacist and the physician together. And in Chetwynd, we'd had a tremendous physician turnover and a crisis in physician numbers. So Dr. Tom Perry from Therapeutics Initiative very kindly came and assisted us remotely in doing the team-based medication assessments in Chetwynd. Next slide. So what is a team-based medication assessment? Essentially, we start off with information gathering, chart reviews, and when we actually then meet the patient, unfortunately, this had to be done either by phone or by Zoom due to COVID, but we had very good communication and started off just trying to understand the patient perspective. What's going on in your life? What are your symptoms? What bothers you the most? What are you worried about? Things like that. And we would then move on to the medications. By definition, they were on 5 or more and they were 65 years or older. So what were the indications for the medications they were on? Were they working? How effective were they? Were there safety issues and side effects which they maybe weren't aware of? And were they taking their medications properly? What was their adherence? So once we'd done all that, it was a question of education and making recommendations, and we sent letters to both the patient and to the physician of their choice afterwards. And so looking at the bottom line there, the provided time, this is interesting. In Dawson Creek, 1.5 to 2 hours per patient. In Tumbler Ridge, the same number. but please remember there was a physician and a pharmacist, so we can double that number. And in Chetwynd, doctors, but the point is in those communities, we kind of knew our patients already. Poor Dr. Perry in Chetwynd had to start from scratch, getting to know someone just from the very beginning with no previous background. And remarkably, with Dr. Perry's amazing diligence and thoroughness, 6 hours per patient on average. So that was a surprise to me, at least. Next slide. So what did we do? This wasn't just simple haphazard deprescribing. In a previous presentation of this kind that I've given, one of the cardiologists said, well, does this mean that all my serious congestive heart failure patients are going to come into emerge now in florid heart failure? I think she was being cynical or joking with us, but the point is no. We recognize that cardiologists have a cocktail involving quite a few meds to treat heart failure. We would never dream of touching that. Whereas with type 2 diabetes, there was just so much opportunity. People were on lots of medications, lots of expensive medications, having side effects. Insulin doses we thought were way too high. Often we would get people off insulin, give them more diet and exercise advice, get them off many other meds because some of them were going hypoglycemic and the HbA1c was too low, all of that. Lots of opportunity there. PPIs were another one. So many people were on long-term PPIs without a good indication. And the only thing here was that we had to go slowly. If we tried to do it quickly, wouldn't work, we'd get rebounds. So we had to be slow and gentle, but just about all of them in the end, we got them off their PPIs. Anticholinergics, probably the most rewarding. There is just nothing like having a lady in her 70s who she thinks she's getting dementia, family thinks she's getting dementia. We take away an anticholinergic and a few weeks later, she's happy as can be, right as rain, family is happy, no signs of dementia. Doesn't get much better than that in the practice of medicine. And finally, in this list here, statins, we put question marks there. This was the area where we actually found the most pushback or lack of congruence with our physician colleagues. We often, in primary prevention situations, we would recommend a trial of discontinuation, etc. And we didn't always agree with our family doc colleagues. So it was interesting. That was an area of disagreement. But looking at the numbers, in Dawson Creek, there were 57 reviews, 194 recommendations, of which almost a half were for stopping or reducing drugs. In Tumbler Ridge, we had 85 people that met the criteria. And we managed to see 79 of them for an hour each. For all the communities, the range was 11, 9, 10, 11 meds on average. But in Tumbler Ridge, we came up with 226 recommendations. So 3/4 were for discontinuations or dose reductions. In Chetwynd, Dr. Perry had an amazing statistic where out of 107 recommendations, 93% were for stopping or reducing the dosages. So that was pretty amazing from Dr. Perry. Next slide. So we got feedback from patients and from their families. And I should say that in most of those situations, we actually got a family member present as well, which was really, really good collateral. So the husband of one of our patients said, we've highlighted what we think, he kind of nailed it. He really got it and he nailed it. So he just said, this is a pharmacist doctor team talking about the risks and benefits of each drug and allowing his wife, empowering her to decide for herself what she wanted to do in many cases. I know he was appreciative that this took an hour. And at the end of it, he said, just sit back and think about that for a bit. What he's saying is this was an amazing opportunity for which he and his wife were very grateful. Next slide. Yeah, so the final element was evaluation. And so we engaged the UBC Therapeutics Initiative through the Pharmacoepidemiology Group to evaluate the project using Ministry of Health data. These results are just coming in virtually as we speak, but it really looks like we have demonstrated a positive effect in our project of deprescribing and that the medication reviews were associated with the reduction in the use of chronic medications. We're very gratified that it seems that our work has actually paid off. And we also engaged Northern Health to evaluate the project, asking pre and post questionnaires to the providers, and it looks like that is going really well as well from everything we can see. So we'd like to give you a short, just over a minute video. This is one of our patients, an 80-year-old male, just over 20 years ago. He had a cabbage, he's got hypertension. About 10 years ago, developed type 2 diabetes. And he has just had the most horrific ongoing shoulder pain. In the video, he says 5 years, but it's 10 years at least. Bilateral, shoulder girdle, left and right rotator cuff repairs he had, then he had a shoulder replacement and goes on. And his life was just miserable because of this. And we just suggested, why don't you just try stopping atorvastatin for a few weeks, see what happens. So here is what our patient had to say.
As much as I could, but it just made it worse, and I tried, no matter which way I tried, I couldn't lift a 5-pound weight past my ear. It would not go up or anything. This lasted like it's got to be over 4 or 5 years now, and I still could not do that kind of until I stopped my medication. This is it. After I had stopped the medication for 3-4 days, I woke up in the morning, and without thinking, I grabbed my toothbrush with my right hand, which I hadn't done for years, and brushed my teeth, and there was no pain. My wife was saying that I was not tossing and turning at night and changing position. I fell asleep in the same position I woke up in the morning. Okay, this exercise here, I couldn't do it without weights, and now I got 3 pounds, and I can do this, I can do that way out there, hold it, bring it back, and bring it down. I can do these. I just can't thank you guys enough for changing my medication. It just now I can go back to fly fishing. Yeah.
Those fish don't stand a chance.
Yeah, I do all my exercise. I feel really good. Yeah.
Yeah, so we know this is an anecdote. It's not absolute proof, but I think it does gives us pause to think and all about statins. Anyway, as a result of all this work that Charissa and I did, a colleague nominated Charissa for a prestigious award and asked me to write a letter of support, which I was so privileged to do. And as a result, Charissa actually won this coveted collaborative care award from the BC Pharmacist Association. And this is just a photograph. It was all by Zoom, of course, but Charissa accepting her award. And the rest of us were just so delighted that one of our team actually got recognition in this fashion. So with that, I am going to hand over to Charissa Tonnesen.
Thanks, Dr. Helm. And I have to say, it's my name on the award, but I share it with all of my collaborators here on the screen with me today. So it was an honor to work with all of you. So I'm going to present a case of one of the patients that we saw in Charleigh Rudy, a gentleman, 69 years old. As Dr. Helm was saying earlier, we always started every session by making sure that we found out what concerns the patient had. And he had several. He complained that he had to pee all the time. He had a dry mouth. He was finding that he was using salbutamol more often recently. And he just thought that he was on too many medications, which was a very common complaint from many patients that we saw. So we went through his list of medications. This is what he was taking when we saw him. He was on 2 medications for high blood pressure, hydrochlorothiazide and twice-a-day ramipril. He was taking rosuvastatin for dyslipidemia. He had recently started dutasteride. He had been taking tamsulosin, but had switched because the tamsulosin was causing dizziness. So that was a recent addition. And then for asthma, he was taking fluticasone and salbutamol for long-term and had recently added montelukast to try to address the shortness of breath issues. We always tried to make sure that we found out what medications people were taking that were not prescribed, And so in the course of interviewing him, we found that he was also taking omega-3. So in terms of the complaints that he had given us, we went down the list to see if there were issues that we could address. So for the first two, having to pee all the time and having a dry mouth, we obviously first thought of the diuretic. In talking to him about the nature of his issues, it wasn't that he was getting up at night to have to pee. It was a daytime issue. And so we thought maybe this wasn't a prostate issue, but instead overactive bladder. We talked to him about some dietary changes that he could make, and we thought about stopping the diuretic. We talked about the frequent use of salbutamol and felt that his asthma medications needed to be optimized. So we looked at that. We also noted that he had been exercising more recently, and that may have had something to do with how much salbutamol he was using. And then of course, number 4, too many medications. We were just going to look at trying to see if there was anything that he wasn't needing anymore that we could get rid of. And so that's where we were going. And so if we go to the next slide, we'll see what we did to his list. So we did discontinue hydrochlorothiazide. We also reduced the dose of ramipril to simplify his regimen a bit so that he only had to take it once a day. We followed up with him over the following weeks, and his blood pressure wasn't as well controlled. So we ended up adding one medication back in, and that was amlodipine. And that seemed to work fine, and his blood pressure was at target after that. We did talk to him about cardiovascular risk, encouraged him to make the lifestyle changes that he was already working on, exercising more, improving his diet. We explained to him that omega-3 really didn't do him much good, and so he elected to stop taking that, but did want to keep taking rosuvastatin. He had not had a rectal exam in quite some time, and so we thought about doing a trial discontinuation of dutasteride after having his prostate exam done, which he did, and he successfully stopped dutasteride and didn't find that his symptoms got any worse. In terms of his asthma, we changed him from just plain fluticasone to a combination of fluticasone with vilanterol. Stopped montelukast. He didn't think that it was making any difference to his medications anyway, and encouraged him to use his salbutamol prior to exercise. And so he was able to get away with just one inhaler once a day, and using the salbutamol only occasionally. So it was a much easier list for him to deal with after that. And I will say, a year later, I looked back at his chart, and he's still on the same medications and still doing quite well. So it was a success. So just in terms of where we come from in the Peace region, there's a lot of agriculture happening around here. And so this is a picture actually from Charlie's farm near Dawson Creek. And I'm going to pass off to nurse practitioner Christy Demeter to continue on with her case presentation.
Thank you, Charissa. So this 74-year-old female came to me as a new patient as a follow-up from her recent visit to the emergency room, where she was diagnosed with uncontrolled hypertension and was subsequently started on nifedipine. She did not quite meet the criteria for the study, only being on 3 medications, but this is an example that highlighted the difference we as prescribers can have with each patient interaction. Making medication reviews as part of day-to-day practice can have significant impacts on our patients' lives, and not just from a drug quantity perspective. Next slide. Now, Sydney happened to be working out of my office that day, and she inquired if this patient had applied for Pharmacare or not. Now, me myself, being relatively new to British Columbia, I was still getting familiar with this program, like which drugs were covered, which ones require special authority, which ones are not covered at all. Fair Pharmacare helps British Columbia families pay for eligible prescription drugs, dispensing fees, and some medical supplies. And Fair Pharmacare is based on income, so the less a family earns, the more help they will get. When I inquired about this with the patient, she had never heard of it and so had not applied. After helping her with this and switching her nifedipine to amlodipine, a calcium channel blocker that was covered, at my next office visit, she was all smiles, explaining to me her prescription bill went from $200 to $20. Next slide. This is a significant impact to our patients who are on fixed incomes or those struggling financially, where some may have to choose between their prescriptions or other necessities like rent, food, etc. This project helped highlight the impact that we have when prescribing and deprescribing medication. And it was because of this close collaboration that I had with Sydney that we were able to make such a significant change for this patient. Next slide. So this is a photo of one of the beautiful canola fields seen here in the South Piece, are usually around July and August, where the golden fields can be seen all throughout our communities. It's very customary for us to have family photos taken in these fields if you're from the area. So now I'd like to pass it on to my amazing colleague and project partner, Sydney, who is our primary care pharmacist here in Dawson Creek.
Christy. As Christy mentioned, because of my primary care pharmacist role, it allows me to be co-located with prescribers and see the patients in an office setting, which may be different than other pharmacist roles. So I had a referral for a 90-year-old male who was having recent falls and changes in his mobility and personality. Because of the COVID pandemic, I met with his family via the telephone. So the family had told me that a couple months ago, the patient started to experience profound grief in the evenings, mourning the loss of his siblings that had died years ago. This grief was both distressing to the patient as well as his caregivers. And at that time, he was started on haloperidol by his GP, but other issues started to arise. The family explained that he was typically quite jovial and able to mobilize well on his own, but since starting haloperidol, he had become quite docile, wasn't sleeping well, and falling frequently. This was causing lots of stress on his elderly wife, who was his caregiver. So taking a look at his medications, he was diagnosed with dementia about 10 years prior, had started quetiapine about a year ago because of some agitation, repetition, wandering at night, and frequent nightmares. The recent haloperidol, like I mentioned, for his cardiovascular medications, he was on Haloperidol, Ramipril, and aspirin. And he had a history of BPH, a procedure about 25 years ago, but tamsulosin was restarted a couple of years ago for some query urinary urgency and never reassessed. So during my medication assessment, there were a couple big flags that came to mind. So the first was BPSD, or behavioral and psychological symptoms of dementia, and how we wanted to go about managing that. So it was pretty clear that a lot of the adverse effects and changes described by the family were related to the haloperidol. So some of the options we talked about were stopping the haloperidol or a dose reduction. We talked about trialing a different antipsychotic that's more commonly used for dementia. That would be something like risperidone or olanzapine that has a better side effect profile. And we even looked at other causes that may be leading to these types of behaviors. Was there an underlying depression that needed some more assessment? Looking at the falls and mobility issues, again, quite clear, a lot of it was related to the haloperidol. But because of his age and his frailty, we wondered, is hypotension a factor here? I got his family to check his blood pressure over the next week. His systolic was 110, diastolic about 60 to 70 for most of the readings. So we know that for somebody his age and frailty, that's quite low. We often have a much higher target. We also know that tamsulosin is linked with dizziness and orthostatic hypotension. And because of his unclear benefit, having had a procedure for the BPH and the unknown urinary urgency that wasn't reassessed, is that something that's even helping him? And then finally, if he's falling and tripping lots, a bleeding risk being on aspirin. So I talked with the family about all of these options. And because of my practice environment, I was able to call the provider and just explain the situation, saying that first generation antipsychotics are not typically used for dementia symptoms. We discussed the blood pressure and cardiovascular risks, the bleed risks and urinary symptoms. And he agreed with the plan that I'll show you here in a moment. And it was, I was going to be following up weekly during these transitions. So haloperidol was the first one that we targeted. The family was quite concerned about the grief and the behaviors that the patient was having prior to starting haloperidol. So they really wanted to taper that quite slowly. So we dropped the dose to 2.5 for a week and then down to nothing for a week. And he did quite well. Once that was off, the quetiapine was targeted. Again, no issues coming off of that. We stopped the blood pressure medications. He was quite stable within his target of less than 150 systolic for somebody of his age and frailty. Stopped the tamsulosin as well. But we didn't just stop all of this willy-nilly. I knew I was following up weekly, and I got the family to keep a close eye on his falls, his mobility, any change in his dementia symptoms, as well as urinary symptoms. So a few months later, the family reported that the patient was pleasantly confused, but had been experiencing more sundowning, sleep changes, and overnight wandering the past couple of weeks. The wife was starting to experience some caregiver burnout during this time. So some of the treatment options that I discussed with the family were non-pharmacological interventions, but again, they had been doing those and they were not effective. We talked about antipsychotic treatment again, but we know that that's not overly effective for the wandering symptoms of dementia. And it does have that increased mortality risk, and we know that he didn't tolerate them well in the past. Zopiclone and other sedatives are not ideal for somebody in this patient population. We did also take a look at the low dose off-label trazodone for insomnia, and that it may be beneficial in this patient. And that's the option that the family wanted to go with. And the physician followed up a couple weeks later. The patient was overall sleeping quite well, and the trazodone had been reserved for PRN use, and he was doing quite well. So my biggest takeaway from this project, and especially this patient, and that a monitoring plan is key. This case was not a failure because medication had to be added. It was a success because our plan allowed for us to determine if there was a need for pharmacotherapy moving forward. And with that, I'll show you a photo of Bear Mountain Wind Park near Dawson Creek on a lovely fall sunset evening, and pass it back to Dr. Helm.
Thank you, Sydney. So yeah, in wrapping up here, we just want to look at what were the challenges that we experienced, what were some of the barriers, and there were some. So the first of these is funding models. My goodness, there really is no funding model for what we did here with the support of shared care, an hour with a physician and a pharmacist. There's no really good funding formula for either of us for that. It certainly made no financial sense for Charissa, my pharmacist colleague, to be doing this. It boiled down to Charissa believing in this, believing she wants her patients on the right amount of the right drugs, essentially a thing called altruism, and that is not scalable to the rest of Canada, I don't think. Work needs to be done in this sense. Another one was the scope of practice. Alberta border is very close to us. In Alberta, Charissa and Sydney would have been able to do more independent work through collaborative prescribing, which is just not permitted in BC. I've been so impressed with my pharmacist and nurse practitioner colleagues here. I mean, they are absolutely more than capable of assuming more responsibility in this regard. But at the moment, that's not really possible. The other concern, obviously, is time. We're all busy, and this does take time. Think of Dr. Perry's 6 hours per patient. Physician engagement, we had great turnout at the webinars, but other than that, it was difficult to really engage physicians. In COVID times, we are all so busy. Many of us are burnt out. That was a challenge. And then there was the challenge of implementing the recommendations. We didn't make changes, we made recommendations. And so if you see it from the perspective of, let's just say, a new young physician in the region, maybe on a temporary license, who gets a recommendation from a specialist to do one thing, gets a recommendation from us, family doc and a pharmacist, to do something. We all know it's easier to increase medications than to decrease them. And we live in a culture of fear, with fear of litigation, etc. So it's quite understandable how in some cases they might not have followed through with our suggestions, or maybe we were wrong sometimes, who knows. But in future, I think, in addition to just sending a detailed letter to the prescribing physician, if I had to do this again, I would actually try and schedule a 10, 15-minute meeting with the physician to discuss each case and why we thought what we did and why we recommended what we did. But Dr. Perry gave us this immortal quote. I now understand why nobody wants to do this work. I just thought that sums it up. It's not actually easy work. It takes time. But anyway, so we have prescriber hesitancy. We also have patient hesitancy. And the best way for me to explain that is just to show you this very short video.
It's a scary process, especially when, for me, I was starting on diabetic medication back when I was in my 30s. So to go so long, and then, well, we think you can cut out this, and we think you can cut out such and such, and we think, and I'm, okay, why do I need to cut it out? Well, why was it prescribed to me in the first place? It's really difficult to make the changes when you don't understand why the changes are being made.
Well, that is the challenge, but that speaks volumes to me. Anyway, what made our project successful and unique? I think we showed one way in which to do this. We all know the theory about trying to deprescribe. We put it into practice in our own way. And I think being in a small remote settings was useful. We all know each other, we're all buddies anyway. Sometimes it's easier in a small place than in an urban center. We did have the time and resources, which was very fortunate. But we had fun, we really, really enjoyed it. We enjoyed empowering our patients, even this thing of going from, if you don't stop any meds, but you go from 4 times a day dosing to once a day, the gratitude you get from patients and the difference you make in their lives and the way you empower them is really, really special. But through this, we had space to develop relationships. We bonded as a team, established common goals, and really, it proved to me what I knew already, which is that team-based care is really what it's all about. We realized the potential, in other words, of combining our skill sets. I know there are many times when, we've all got strengths and weaknesses in our skill sets, and to have the physician and pharmacist together with the patient, there are so many things that Charissa picked up that I wouldn't have, and I would think maybe vice versa as well. So we know that we did our patients a good deal by combining our skills and meeting with them together. And that the quote there at the end is mine. It's the most fulfilling work I've ever been involved in. That's to do with gratitude, because the amount of gratitude that we receive, genuine gratitude, to me, it took me by surprise, but it shows how, people need this, people appreciate this. And to me, it's, the reason I feel that way is because it's one of the most amazing ways that you can actually make a difference in patients' lives, is by changing and reversing some of the decisions that you might have made in the past or that your colleagues made in the past. So it's a bit ironic, but that's basically my quote, and that's how I feel. But I think we all share that kind of just feeling of being involved in something worthwhile and a job well done. So with that, I'm going to hand back to Sydney.
Great, thanks, Dr. Helm. So to wrap it up today, we want to say a special thank you for Therapeutics Initiative for having us here today to share our project, Dr. Tom Perry for his guidance and participation throughout our whole project and his work in Chetwynd, Dr. Lynelle Saccharin, who was involved in our evaluation from the Therapeutics Initiative, and Raina Farnes, who was our project coordinator. And finally, if I can leave you with one thought for today, if you're starting to identify polypharmacy in your practice or looking to deprescribe, one thing I wanted to share is choosing to do nothing is still a decision that can lead to harm. So go ahead and start today, start that conversation. So with that, I'll share the beautiful Northern Lights from Dawson Creek last fall and open it up for questions. Thank you.
Well, terrific. Sydney, Christy, Charlie, Charles, Charissa, amazing. And you managed to do it in 35 minutes. So you have an absolute record in this Therapeutics Initiative webinar series. There are beginning to be a few more questions. And I think what I'll do is just start with the first two that were posed, and then while you're answering them, I'll catch up on the other ones. And people may continue to submit questions or comments. If we probably have time, if anyone wants to make a brief comment verbally, if you could let me know by just sending a chat message to me, I think it may be possible to recognize some people. So the first question I've got is from Fidelia on the benefits of statin in people who are very elderly, over 85, saying statin is often being considered to be prescribed for advanced, frail elderly, especially in long-term care. Is it simple? It is simple to stop that, I guess, if it's primary prevention, but what about remote secondary prevention? For example, someone who had coronary artery disease or a stroke more than a few years ago. And I think it could be combined perhaps with a question from Dr. Douglas Falder in Edmonton, medical director for long-term care Did you and this project make any interventions for long-term care or residential care residents?
I can try to answer that with regard to the statins. I think the evidence is conflicting. I mean, I have been going with the evidence just says beyond 80, is it really worthwhile? And unless they're absolute, and recognizing that you get healthy 80-year-olds and frail 80-year-olds, we understand that. But I've tended towards, gee, here's one thing we can stop and it might be causing side effects. I know there's evidence now that is sort of pushing us a little bit the other way, but even in the extreme cases, people with dementia that we see are still on statins, or people with, advancing cancer that are still on statins. It's like we're addicted to this drug as prescribers. And I mean, I agree there possibly are cases where, you can make a case for it, but our perception was just, we thought we were seeing way too much of it. I wish we had done more work in long-term care facilities. We tried a little bit. I don't think we've done as well as we hoped to when we went into this project. There's some things that went really well. That's one area where I wish we could have done more work, but yeah.
And I can comment on that, Dr. Helm. At the time of this project, the pharmacy services were contracted out to a private community pharmacy. But in that time, Northern Health has taken on the responsibility. So we're starting to do that work across Northern Health now for some of the facilities, which is great to see.
If you're ready for another question, Carolina, I don't know where Carolina is or what profession, but asks, how can we prevent unnecessary polypharmacy as healthcare providers in the future? It seems as if it's up to the primary care provider's own initiative to do that. Systemically, should we establish a checking system to review each patient's meds in a given time period? Any thoughts on that?
Yeah, I think that's a really good idea. It is sort of at the moment just up to us, which is not a really good way to do it. I know, Tom, you've been thinking of ways to take the kind of thing that we've done and make it applicable to a broader base and making it more orderly or almost a requirement. But the other problem is that the scope of this is so enormous. I mean, we think we've done reasonably good work here, but we've just scraped the surface in one little area. It's an enormous problem, and we're not going to solve the problem by individually making a decision. Let's try and do something about it. I would totally agree with you. There has to be something at a systemic level, if I can use that word.
I'm just going to pause to let Eric know if I'm missing anything. Let me know or speak up. I think the next question is Brenda Schuster, who's a pharmacist with a long experience in this field in Saskatchewan, says, I might have missed it, but were the appointments always doctor, pharmacist, and patient, or nurse practitioner, pharmacist, and patient at the same time? Did you ever try the pharmacist first, then the doctor, pharmacist and patient right afterward, where a pharmacist does some of the background work before a team discussion?
Yeah, I think those are all good points. We actually said we got 3 communities and we took a different line in each community. So we weren't identical. In my community, which is Tumbler Ridge, the pharmacist, the physician, and the patient, and normally a family member, always met. We never did it individually. In Dawson Creek, it was more individual from Sydney as the pharmacist, with a lot of collaboration with Christy, the nurse practitioner. And in Chetwynd, it was collaboration between yourself, Tom, and the pharmacist there, and then these remote visits with the patients. I mean, all the other suggestions are feasible, but I think once we had started down a certain road, in terms of the evaluation and everything, we wanted to keep it a certain way, but they would all be feasible, absolutely.
And I can comment from the Dawson Creek perspective, where it was me meeting with the patient and the family first, doing our 45 or hour long appointment, and then me meeting with the prescriber for 5 to 10 minutes after to debrief, give my recommendations, and then make a plan moving forward with the patient. I think that's something and a model that might be more possible moving forward and to scale to other places than having a physician and a pharmacist together. But we can clearly see the benefit that Dr. Helm and Charissa had being in the same room. They said catching things that the other may not have heard. So, I mean, ideally, you'd want all of the professionals to come to the table, but we have to be creative in the way that we use these models.
Yeah, I can add that in Chetwynd, which is a community of about 3,000 people, one pharmacist became quite involved for a while in attempting careful medication review and suggestions in advance and sometimes in follow-up, and was particularly helpful, I think, with a patient who was very reluctant to change anything and was on multiple psychotropic medications. And if we had been able to sustain a longer term working relationship over a period of more than a few months, in that case, probably would have made more progress. There are a few more questions here. Joanna Trimble, who's a prominent patient advocate known across Canada, asks, how can we make planned scheduled medication reviews a part of our medical system in primary care? Can we get a new billing code under Medicare introduced for this kind of work? Anyone want to comment on that?
Well, I think that's what we were getting at, Tom. Ideally, yes, we do. This is what we need. Currently, we could do this because we got funding for this project from Shared Care, which is a combination of the Ministry of Health and Doctors of BC in British Columbia. It was almost like a unique opportunity that we grabbed. But what we're saying is this is not applicable generally, and one would need, I absolutely believe in a billing code for this, and something that for the physicians, and something that allows the pharmacists to bill appropriately as well.
Yeah, I'd like to step in here. Like pharmacists are able to bill medication reviews twice a year for patients every 6 months, with follow-ups in between for kind of shorter things. So there is a mechanism within pharmacy, and I don't know that it's utilized to its fullest extent in community pharmacy, but it is an option.
I'll just draw everyone's attention in the chat. You can see that Jen Duncan and Sean Baird have pointed to the new primary care clinical pharmacist initiative in BC, and a link in which you can explore that a bit further. There's one comment that was sent to me, but not everyone will be able to see it. Dr. Mike Kolber, academic family physician in Edmonton, had to leave early, but he says hope you publish pre and post mean number of medications and follow-up. And I think the South Beach group are working on that. Of course, it's rather complicated to figure out what that means in a way that one can publish it, but it's in progress. There's some more questions here. I think I'm going to say, because we have 11 minutes left, I'll reserve 5 minutes in case somebody actually wants to comment and unmute themselves and make themselves visible. But the next one is, I think it was interesting in the one case that aspirin was stopped for the patient who had coronary artery bypass graft. Was the risk of falls or something else considered to outweigh the benefits? Can you explain that?
Yeah, I think that was Sydney's case. That was the 90-year-old male who was somewhat confused anyway. So I think in all of these situations, it's weighing up the risks and the benefits. And I know if this was my patient, that would come out on the side of stopping the ASA. Others might fault that, but that's the decision that I would have to live with. And if something horrible cardiac went wrong, I'd have to live with that. But one wouldn't want to see this patient falling and having a big bleed. Sydney, did you have a comment on that? Because I think that was your patient.
Oh, it was more so that it's not us as providers to make that decision. It's to give that information to the patient and the family and allow them to make that decision based on the risks to them. This gentleman had fallen and had a pretty good laceration to his forehead shortly after stopping the aspirin. So who knows if the outcome may have been different had we left him on it. So you're never going to know 100%. It's using the information that you have and letting the family and the patient make the decision that's best for them and their risks.
I'm going to ask one of the Northern Health people, maybe Charlie, is it possible to share the link to the 9 CME webinars that were presented as part of the South Peace project? Oh, it's good. Okay. Is that open to people who are not affiliated with Northern Health Authority, or is it now going to be public?
Yes, so these webinars are now on the Shared Care website that I just linked. You will find them. It's under South Peace Polypharmacy Project Learning Sessions, and all webinars will be there for everybody to view. So not just for Northern Health, for public.
Good. Dr. Falder has posted a link there, which I hope someone from our group will click on. I don't dare click on it in case I lose my visualization of the speakers today. Or Dr. Falder, you could send it to me at tom.perry@ubc.ca. Carolina, just before Carolina's question, Brenda Schuster, because of your experience in Saskatchewan, I'm going to invite you to comment if you wish in a second. So you maybe could turn on, or Eric can let you turn on your camera. Carolina, a medical student in British Columbia, asks, does anyone have any estimate of the approximate number of patients who are probably currently overprescribed medications? And anyone in Canada, I guess, anyone wish to tackle that? I think we lost Barb Farrell, who's an expert in this in Ottawa. She had to attend something else, but.
I would say for older adults, pretty much everybody would have at least one medication that's unnecessary.
Yeah,
that's what I would say. If it's on a teaching service in Vancouver, it's probably at least 2 to 3 per patient.
Yeah, I would think, Tom, that you're in the best position to answer that of all of us here. But I mean, how many seniors over 65 are there in Canada? Many. And I think, as we've said, the majority of them, you could tease it out and find a couple, and you would make their lives a lot easier and free of side effects and so on. But the problem is, if we stop a statin and then someone gets a stroke, even though it probably would have happened anyway, we all know how you second guess yourself. Did I make a mistake? What would have happened? You know, but those are risks we have to live with, I think.
The one of the, just for the student who Carolina asked the question, one common example might be insulins. More than one type of insulin, for example, for someone with type 2 diabetes. That was a fairly common issue in Shetland, where or sometimes prescriptions for multiple insulins, not all of which had been filled or utilized. They might be shown in PharmaNet, so one could tell it had been dispensed, and yet the patient wasn't actually using it. Just before we go to Brenda Schuster, can I take this question from Roseanne Talakada, who says, when you made drug changes, did you often make one at a time, or were multiple changes made simultaneously?
Yeah, we tried, you know, we knew, again, small town, we're not going to lose these people. We know we're going to have follow up with them. In general, we would try one at a time and have a plan for over the next couple of months. Here's what we're going to do. In 2 or 3 months' time, you're going to be off this and that, including your PPI, but it's going to be gradual. I can hardly think of any occasions where we just like cut everything cold turkey. Yeah. And I mean, some of the medications were fairly easy to stop, like non-steroidals. Other things like hypnotics, the Z drugs, the benzos, etc. We knew that this, you know, it might even take longer than 3 months. It might be 6 to 12 months. But the important thing is to get the plan going.
Okay, Brenda Schuster, would you like to make a comment? Make sure you're on.
Yeah,
muted.
I would just say that I'm just trying to remember some of the data that I've read over the years, and certainly it looks like some people are posting some things from CIHI, and someone like Barb Farrell would be able to quote the numbers exactly, but looking at literature that looks at medication reviews and looking at identifying drug problems for potential deprescribing. I know the piece, often the literature will show quite a range, and it will depend upon the patient population, as you can imagine. A lot of times you'll hear anywhere, about 2 to 8 drug-related problems being seen in one medication assessment. And then as far as how many of those result in deprescribing, that I can't remember the data, but that's just a general remembering as best I can. And the other thing I just wanted to pick up on, Tom, just because you've got me off mute, is just that comment from the patient, that one vignette where the patient expressed, this is kind of scary. For all these years I took it, and now it's like, oh, it's okay to stop. I'm sure we all see patients with that, or have had experience with patients with that, expressing that concern. And I think there's a lot of patients that don't necessarily express it. And I think as we go forward on these journeys, we always have to remember that it's a very normal feeling for a patient to feel that way. And we have to be able to really go alongside them for them to feel comfortable about the deprescribing piece and understand why things are different now. And that's not that we're giving up on them. I'm saying something that we all know, but I just think her point was very well made and very important.
Good point. And part of so-called indication-based prescribing, where one writes the purpose of a drug in a prescription, might also be putting some term limit on it or an instruction to review. For example, something in naproxen 500 milligrams twice daily for gout for 2 weeks or for 1 month, brackets, please review after 1 month, even if there are renewals authorized. I think we've dealt with the questions. If there's anyone whose question I've missed, please post it again. Southeast, do you want to make any final comments before I thank you?
Tom, I can just say that I learned a lot through this, but many things. But one of the things I learned was, well, I didn't need to learn it because I knew it already, but the value of team-based care, but learning how much nurse practitioners know and how much pharmacists know and how their skills can combine with my skills as a physician. I've been in this as a physician for 40 plus years, but I could learn that afresh. And to me, the value of team-based care, that's the take-home message.
Any of the rest of you from Southeast want to add something? Or do you intend to finish early?
I think I would add one thing. One thing that I've become a lot more comfortable with is talking to people when they first get a medication about how long they should expect to be on it and when they should think about coming off of it, rather than just saying, here, you're taking this drug, come back and get your refills. And I've certainly, like I had a guy that I casually talked to him about, do you really need tramadol still, or do you want to start exercising to help with that back pain? Came to me yesterday, he stopped the tramadol and bought an elliptical. And, those kinds of things can be quick, casual conversations, and we should be doing them all the time. And it doesn't always have to be an earth-shattering, go through every drug and make every change. It can be something we do with every interaction with a patient.
I'd like to thank all of the Southeast group for their amazing work and a beautiful presentation. You set a very high new standard in this series of webinars. Thank you, everybody, and bye-bye, and I hope we see you in 4 weeks again.